Hello, my name is Neil Srinivasan. I'm a consultant cardiologist and electrophysiologist. I specialise in the management of heart rhythm abnormalities, and today I'm going to talk to you about atrial fibrillation. Atrial fibrillation is the most common heart rhythm abnormality in the world. In the UK, around 1.5 to 2 million people are troubled with atrial fibrillation, and I see it all the time in my clinics. Atrial fibrillation is characterized by the abnormal contraction and beating of the heart. The upper chambers of the heart, known as the atrium, govern the heart rhythm. And in atrial fibrillation, the upper left chamber, known as the left atrium, starts to become disorganized. It is a condition of aging. We see it more common in patients who are older, or particularly after the age of 60. But it's also a condition that I see more frequently in young people more and more. And there are many reasons for that. Some of the reasons are because patients are unlucky and genetically have a susceptibility to atrial fibrillation, but also some of them are environmental and structural. People with structural heart problems, people with underlying heart conditions, and people who, for example, have hypertension or obesity. I also very frequently see atrial fibrillation in people who exercise a lot. I treat a lot of endurance athletes, people who cycle a lot, people who do long distance running, and they're often troubled by atrial fibrillation. And the problem with atrial fibrillation is that when you go into this rhythm, your heart is not beating in a coordinated fashion. The top chambers and the bottom chambers of the heart are not talking together. The upper chambers of the heart, the atrium, are often beating very rapidly and chaotically, and the bottom chamber of the heart, known as the ventricle, then beats at random heartbeats. So, as you can imagine, if you're trying to exercise or walk up the stairs, and your heart rate is not the right heart rate for what you're trying to do, you will get symptoms of tiredness, fatigue, breathlessness, palpitations, fast heart rhythms, and feel unwell. Some patients with atrial fibrillation feel dizzy. There are also a number of patients with atrial fibrillation who we see more and more who develop symptoms of heart failure. The bottom chambers of the heart, known as the ventricle, start to become weak. The bottom chambers of the heart then become more dilated and stretched, and some of the heart valves start to become leaky. As a consequence of this, patients really suffer with symptoms of atrial fibrillation. In terms of my practice, the first effort or first stage in treating atrial fibrillation is thinking about how we are going to diagnose whether patients have atrial fibrillation or not. The simple way to do that is through an ECG. Sometimes we fit longer-term monitors to try and diagnose these conditions. Sometimes atrial fibrillation comes and goes. It's sporadic and it's quite hard to diagnose, a condition known as paroxysmal atrial fibrillation. But in some people, they're in atrial fibrillation all the time, persistent atrial fibrillation, and it's much easier to catch. Increasingly, I'm finding patients who buy smartwatches, for instance, and they're an excellent tool for diagnosing and picking up atrial fibrillation, and a great way of then attaching the cause of people's symptoms to the actual heart rhythm itself. Once we've diagnosed atrial fibrillation, the management then structures around two key aspects. So the first aspect of management is in trying to prevent stroke in atrial fibrillation. The chaotic beating of the upper chambers of the heart can cause stroke, and around 25% of strokes in the UK are due to atrial fibrillation, either diagnosed or underdiagnosed. And we have algorithms and guidelines which can then base our decisions with regard to whether patients should receive blood thinners to prevent them from stroke. The second aspect of the management of atrial fibrillation is what are we going to do about the atrial fibrillation itself? There are three ways in which atrial fibrillation can be managed. In patients who get sporadic bits of atrial fibrillation, paroxysmal atrial fibrillation as I described earlier, and are not very troubled by it, maybe you get atrial fibrillation once a year, it is completely acceptable to leave the atrial fibrillation alone and see how things progress. But bear in mind that the general history of atrial fibrillation is that patients tend to get more and more atrial fibrillation with time. In some patients who are in atrial fibrillation all the time, in persistent atrial fibrillation, they do not get symptoms. They do not get valvular heart failure, and they do not get heart failure itself. And in that setting, it's also okay to leave the atrial fibrillation alone. But there's increasing data that says where you leave atrial fibrillation alone, patients after 5 years who are left in atrial fibrillation do more poorly than patients who are treated by trying to get them back into a normal rhythm. The other two ways of treating atrial fibrillation are strategies to keep patients in a normal rhythm. and they can involve the use of medications such as beta blockers to try and keep the heart in a normal rhythm, to try and stop the upper chambers beating chaotically. One of the problems I find with medications is that a lot of my patients struggle to take medications, particularly younger patients, because beta blockers and other medications we use to treat atrial fibrillation often cause the heart rate to be slower. They can have side effects, making people feel tired and lethargic, and they often restrict the amount of exercise you can do. Which is why a lot of my patients often opt to consider the third option, which is a procedure called catheter ablation. This is a procedure where we try and treat the abnormal cells within the heart that cause atrial fibrillation, and it is the most successful way of keeping patients in a normal rhythm. As with all operations, there are some risks and side effects from doing a procedure, and in my clinics I have very comprehensive discussions with my patients with regard to how and when we should proceed with catheter ablation, and in detail how catheter ablation itself is performed. When you have catheter ablation, this is normally done as an overnight stay in hospital. In private practice, I very routinely do this under full general anaesthetic, and most patients wake up within 1 or 2 hours from a very quick and straightforward procedure and are able to go home the next day. Patients may experience some soreness in the leg after the procedure and some soreness in the chest, and normally have to take a week off work, and I normally recommend against strenuous exercise for the first 2 weeks. But most of my patients within 2 to 3 days are able to do long walks and recover very normally, and then we go on and assess the effects of the ablation and look and see if we've improved symptoms and improved patients' outcomes.